And we're live. Hey, everyone. Good to see you all. We'll do some quick intros and then we'll get going. I'm Joseph Shapiro. I'm an attorney in New Jersey. I also practice in New York. I'm a partner with Middlebrook Shapiro out of Springfield, and I'm on the executive board of the Cannabis and Psychedelic Law Committee of the New Jersey State Bar Association. Also co-founded the Psychedelics Subcommittee. And I'm a co-founder of the Psychedelic League with Sarah Price.
Hey guys, Sarah Price here. I'm a registered nurse and I'm the founder of Flourish Health, which is a functional medicine nurse coaching practice. And I am also a certified combo practitioner and co-founder here at Psychedelic League, and super, super excited to have Dr. Hannah McLane with us. So good to see you.
Good to see you too. Thanks for having me.
Yeah, so a little bit of an intro and a bio for Dr. Hannah. Really interesting background. Dr. Hannah is a physician, psychoanalyst, and entrepreneur. She's the founder of Sound Mind Institute, which is a rigorous facilitator training program and research initiative aimed at bringing ethics, equity, and innovation to the psychedelic ecosystem. She grew up in rural New Hampshire and spent several years in South America and East Asia. Dr. Hannah conducts research on cognitive diversity, psychedelic science, ethics, PTSD, and emerging alternative therapies for mental health issues. She identifies as neurodiverse, having both dyslexia and ADHD. Dr. Hannah attended McGill University and holds graduate degrees from Temple University, which is a master's in communication sciences and Spanish language, Brown University for a doctorate of medicine and contemplative studies concentration, and Harvard School of Public Health for a master's of public health in global health and bioethics. She attended residencies in neurology and occupational and environmental medicine from the University of Pennsylvania and completed a fellowship in patient safety at the VA hospital in Philly. She also completed a 5-year psychoanalytic training program and considers herself a relational psychoanalyst. Did I hit?
Yeah, wow. You read it really well.
You have an extensive background.
I like how the only word you mispronounced was dyslexia, which means you...
Did I really?
Go get tested.
Well, I've already got the other one, so might as well check for that one too.
Hannah, I actually Googled you before just to see. I don't know what I was looking for, but when it popped up, like your website it's very impressive. We love that you're like the star witness in New Jersey legislation world these days too, because like I can't imagine anyone with a better, well-rounded bio.
Thank you.
Absolutely. And something I was thinking about this morning was your background in the occupational and environmental medicine and the ability that you have to speak to the influence that psychedelics can have in a workplace. Joe and I have spoken to somebody else who's involved in more of like getting the workplace involved, Jessica Tracy, who we're going to be interviewing in another couple of weeks. And what a perfect sort of combination there of here is why it's important and here is how you can pay for it.
Totally. And Jessica Tracy trained with us too. She's amazing. And highly recommend anything she says. I would also say it's interesting because the occupational environmental medicine is relevant both for workplace and understanding environmental factors and how they influence mental health. That was what I kept doing projects around mental health, and they're like, you were the first one who this is your focus. But I was really interested in how the environment affects you, not just you as a depressed human, but what is going on around you, the social factors, and then also. The aspect of you learn about toxic exposures and how that can cause trauma. I'm very fascinated with that as well. So it's the most random residency is particularly relevant to all of my interests in psychedelics right now.
That is so fascinating. I work with a program using sauna and niacin, from a detox standpoint. And it's incredible what heavy metals do to the brain. Heavy metals, persistent organic pollutants.
Lead, weird things what's in Teflon, PFAS, PFOA is also in high in the water in Philly. So you learn these things and you're ooh, that doesn't, it affects your hormones. I think there's a lot of people that think they're getting poisoned by everything, but then there's also real stuff happening that is really important for us to know about mental health and also just how to stay well. You can't just go to a 2-week ayahuasca retreat in Peru and then come back to toxic social environment and physical environment and think you're going to be okay, you know?
That's really fascinating. It kind of speaks to some of the centers, you know, where there is like a health component and also a psychedelic component, like the importance of both of those.
Totally.
I definitely want to come back to that last statement about you just can't go to a retreat and come back okay, because I think it's such an interesting kind of trope that's going on in psychedelic advocacy. Is it's such a great argument that it's a one pill, it is a panacea, one time will do it, because I think that's a great selling point. Then why wouldn't we want it? But we might be shooting ourselves in the foot if we
it's like the one pill shows you everything that's wrong, you know, with your life, and then you're like, oh shit, what am I going to do about it?
And then Sarah and I talked about this week. We said, you know, some people would say, well, why would you want that then? Why would you want to go through a hard thing that shows you everything wrong? I'm just happy not doing that, and I'm doing fine. And it's like, it's a hard, I mean, making a good point. I don't know why. It's just, if you're into growth, I think that perhaps that's what you want.
Yeah, and people that think they're doing fine might not be a good candidate, right? I would say I have a family member that I thought really should go to therapy, and they went and said, oh, the therapist said I'm fine, I don't need a therapist. And I was like, well, that can't be true. You have tons of trauma. That can't be true. But it's also true that you can't work with someone who doesn't think there's anything wrong, you know, or doesn't see any development to be had. So it's like, if people are in contemplative mode of, you know, it's kind of like, you know, where is someone in the wanting motivational interviewing teaches us this, like you can't get someone to quit smoking cigarettes if they don't want to, or if they don't have any desire. So it's really, you have to hit someone where they're realizing there's some growth to be had. And then we also, you know, in the clinic, and you know, in our ketamine clinic in Philadelphia, and then international psilocybin retreats that we do, a lot of times people will come out and say like, oh my God, I didn't realize how bad I actually was. You know, I didn't realize how suicidal I was. I thought I was like fine. And then now I realize what it feels like to feel better.
Yeah, you know, having to put a label on being well or not is a tough thing. The growth, you know, the idea that it can give you some growth is maybe a different way to address it, you know. And I guess we keep coming back to messaging, because with Psychedelic League, we're really focused on tight messaging, so we can talk to municipalities, mayors, council members about why would you want this in your, you know, in your backyard.
Totally. Can you give me 1 second? I have a child knocking on my door.
Oh yeah, here, no. Bring him over. Yeah. Yeah, I think it's
you know, it's interesting the way, you know, like when you look at like any sort of coaching, somebody has to like at least be able to observe a problem and like see like a reason for change. Like, and sometimes that can be that they're so fed up with where they are, but they have to at least see it. But if they see no problem at all, then it's really tough to go and do something tough, because you're like, no, this is all good and it's working. And even though there's like a fire behind them, they're surrounded by chaos. They're like, nope, this is great. Excellent.
Totally. Yeah.
In speaking with people who are running service centers currently, there doesn't seem to be a shortage of people who recognize that they need or want psychedelic therapy, and they don't need much convincing. So it's probably not as much convincing, you know, people who would be undergoing therapy or, you know, taking psychedelics, period. I think it's really about, again, the messaging that I'm obsessed with these days is, you know, how do you pitch this as something that to people who might have no idea? It's a really interesting challenge. How do you pitch psychedelics and therapy to people who have no idea what that means at all, you know, and what they would expect people to come out of it with, you know, the experience.
Yeah, and I would say like my dad, when he's now has gotten into plant medicine, but I originally sent him the books How to Change Your Mind and The Fellowship of the River by Joe Tafur, just to be like, you know, you think what I'm doing is really weird, but just read this, you'll have a better sense. And then he read them, and then he was like, the plants are calling me. And I was like, no, Dad, no, they're not. No, stop. And he's like, no, they are. You know, so sometimes it's just a book that people have to like sit with if it feels like you're pushing something that people don't feel like they need, then I wasn't even giving the book to get him into it. I was just giving him something so he didn't think I was crazy. But now look where we are, like many retreats later. He's doing great.
I was leaving my jujitsu gym a couple of days ago, and I saw a guy reading How to Change Your Mind, and I said, "Oh, interesting. What do you think?" And he said, "Yeah, I'm reading this because I'm going to go to my first psilocybin retreat in the Netherlands." I said, "Oh, very interesting." I said, "I really think that book and then the media that came out of it has been so influential. I mean, it's huge. The impact can't be understated."
And then there's the Netflix, 3 series shows about it as well, which is cool. It has Sarko is in it, and he was I trained with him with MAPS, and then he was also did our training, and we've done a lot with him, and just a lot of great people. So, I think, and that's like for people that don't read, if you're also dyslexic out there, there's a video.
We have different, I've had recently discussions, like I listen to audiobooks almost exclusively. It's like, is that as good as reading? You kind of feel like a little bit, maybe I'm not a reader per se, but no, it's a valid way to take in information if you're retaining
It's definitely reading. And in fact,
Yeah.
A lot of people with dyslexia say I'm like reading the audiobook just because it's like, oh, book I'm reading, so that it doesn't feel like, it's not ableist, the language we're using. Yeah.
Yeah, I like that. Yep. I think, coming from someone who was slightly dyslexic as a kid, I think that's very reassuring.
Yeah.
That's really well. I'd love to kind of jump in a little bit to like training in general. Back with your the co-founder of Sound Mind, which is a super well-respected facilitator training program. And I think there's a lot of folks who don't understand that terminology, right? Outside of there's even within the healthcare system, the word facilitator is not used. So how would you describe what is a facilitator to the mayors out there, to the congressmen, to the public? What even is a facilitator?
Yeah, so great question. I think you would explain it differently to like a therapist or to a layperson or to a politician. And depending on the background of politician, as Janine was explaining in our webinar recently, a lot of the people on the recent hearing that happened a lot of them were doctors. So it's like you speak differently to a politician doctor than you do to a politician non-doctor. But I would say, first of all, I'm the only founder of Sound Mind, and I own 100% of all my entities, and we have never had investors or donors because I believe in autonomy and not getting swayed into different areas of ethical gray areas with investors. So that's the first thing.
Full disclosure, right.
And women run, and so that's Sound Mind. So a facilitator, it's interesting because there's different things that you learn so we have a 250-hour training program. It started out as a 10-week intro to psychedelics in 2019. And it's mostly because I was rehabbing this building. So I do real estate on the side, and that's part of the way that I'm able to fund some of the psychedelic initiatives, because a lot of the psychedelic initiatives, although it looks like people should be making money and things are expensive to get, it's expensive to get trained, it's expensive to get treated. It's a really hefty overhead because you're paying lawyers to help you understand all the legalities, and you're doing a lot of, Ezra just gave me a half of a strawberry. It's not real, he said. So rehabbing a building to turn into a clinic, and I got a lot of interest in working at the clinic because we were thinking, okay, we're going to do ketamine-assisted psychotherapy, and then we're going to do MDMA-assisted psychotherapy when it's available, and hopefully psilocybin-assisted psychotherapy when it happens. And then I got so much interest from local people because there was so much interest in working for our clinic. And I was like, how am I going to address 100 people who want to work for us? So then I started this intro to psychedelics class in 2019. And I just brought on people that I considered experts at the time, like Rick Doblin, Michael Mithofer, Joseph McCowan, many people in that early cohort, and it went really well, and people wanted more. And so at that time, it wasn't a training program, it wasn't anything. It was just a 10-week, like, what is psychedelics? And it has slowly since 2019 developed into a 1-year training program. It's 250 hours. It has a practicum component that you have to actually sit with someone on medicine. But we really focus on both the sitting with someone while they've taken a psychedelic and helping them process afterwards. And so process afterwards is integration. So some therapists or even coaches don't necessarily want to sit for 4 or 8 hours with someone while they're taking a psychedelic, but they do want to know how to help them process. And so this course, to me, I think you really have to understand what it looks like to sit with someone during the experience to be able to really help, even if it's not the same person, but understand what the experience like contains to be able to help them integrate properly. So we focus on sitting and integration and preparation. We do a lot of work on like ethics, informed consent. How do you make sure you are acknowledging the fact that when someone goes into a psychedelic, they're in a more malleable neuroplastic state. So really respecting that and helping them make choices beforehand about what kinds of things will feel supportive during the session. But for someone who doesn't know anything about what a session looks like, so basically if it's ketamine, you're going to hand them the ketamine or give them an injection, and then they go into a period of what I would consider kind of a waking dream. So as a psychoanalyst, that's part of the reason I really love psychedelics, is you're kind of like walking through someone's dream with them and really trying to understand all the symbols and all the unconscious material that's there. And so some people talk through it and some people just lie there, but then as they're coming out, they'll have things to say. Like, wow, I felt like really supported when you told me I was safe, or I felt like I was like flying through Egypt and then I saw my mother who died 10 years ago and I gave her a hug. And so you're there, the sitter or facilitator or guide, it's, they're all just different words for the same thing, is helping the person process. And it's really important to be there during the session and in the time afterwards, and then also be available the next day if anything comes up. Sometimes the material is frightening. Sometimes unconscious material comes up that someone didn't even know about. They might realize they had like abuse as a child that they don't remember. And so it's really important to be there to hold space for them. And mostly what we're doing is calling it non-directive therapy, or non-directive support. And so you're not like telling them to do anything, although there are going to be people that will look into this kind of space holding. But what we do is we're not saying like, go towards this, go do this, or like, find your younger self. You're not explaining instructions. You're just waiting for them to talk, and then you respond in a supportive way. And so that's what the training program is we do a lot of work on yourself. So meditation, learning all different techniques for processing your own issues, because when you're sitting with someone that has stuff coming up, you really need to keep yourself stable in the time of and after. So you do get a lot of vicarious trauma through this work. I've had a lot of patients with childhood sexual trauma, just like really sad stuff that comes up. So you really need to know how to process it yourself. So it's a big part of the training program. And then how to help the other person process their things, and how to do it in a way that's really grounding and supportive. So like different types of meditation you can use on yourself, you can use on the person you're working with, different ways of preparation, different ways of helping someone understand what they saw. Sometimes people will go into a psychedelic journey and just see like shapes and colors, and they're like, that doesn't make any sense at all. So what you don't want is someone storming out and being like, I didn't get any messages. What you're trying to do is help them understand that the messages sometimes come in different ways. They might come in a somatic way. It might come in like a feeling of anxiety or panic. Sometimes people with a lot of anxiety and panic in life go into the journey and get like extreme amounts of anxiety. I had this one person that came in and she was like on benzos, so anxiety meds, like a lot for chronic anxiety. She went into her ketamine journey, had like what seemed like a several hour, like close to a panic attack. She was just really like, I'm so scared. And to me, it was a very hard journey to hold space for. But then she went home and just never took benzos again, and her anxiety was gone, like weeks and months after.
Wow.
Like I still don't totally understand that. And it's actually like surprising to be able to just taper or cold turkey off benzos, because usually they can be considered quite habit forming. But it's almost like all of her anxiety came out all at once, and then she was like done with it. Or she was like seeing parts of it that she couldn't see if she just suppressed the symptoms. Yeah, and I think for people that don't know anything about psychedelics, a lot of it is like bringing up symptoms and bringing up underlying causes of symptoms that you can't necessarily access in your conscious mind. So it's stuff that's might be deep down, scary, might be memories that you don't even quite remember, but that are kind of bogging you down, that come up, and then you can process them. We see that a lot. And so the big goal in psychedelics, which is different than a daily medication, is you're trying to get at the underlying cause and cause some permanent healing. And that doesn't mean it's like a one-time, one and done, that's it. But it means like you're slowly, each journey, each psychedelic experience, you're kind of digging up, excavating under what's going on. And then, eventually the goal is you don't need daily medications, or you don't need symptom reduction.
I think that's a beautiful way of saying it, because, as Joe was talking about before, the one and done kind of concept, or maybe people think they only do two. And there are certainly people who go to psychedelics one time and walk away and we're like, oh, nope, I'm good. That is good for me. But for many of us, who've worked with them, like it kind of tends to be just sort of like it's a process. It's a process of diving in again and uncovering more. That's really beautifully said. And I think what's really awesome too with the way you just explained that is, in terms of the process, one of the questions that came up at one of the hearings I was attending that you were testifying in was it was a senator, I believe, who was really concerned that this was not being done. The facilitation was not being done by an MD or somebody with very high level of training. And it kind of goes to show that the kind of training, this is a very, very unique kind of training. It's not something, that is, taught in med school. And so this idea that, they only have to have a high school diploma was really kind of disconcerting for some. And I remember your response to him was like, wait, this is intense training here, and it's quite different.
Yeah, it's a very rigorous training program. I think SoundMind is known to be maybe one of the harder ones to get through. And it's partly because I want to create a program that people can keep going back to. So even once they're trained, there's like a ton of reading that's like optional that you can go back to. And it's like a really amazing reference. We do psychodynamic technique training as well, which is like a type of psychotherapy. So I'm really teaching them the different types of concepts around therapy, which I think are really important, like transference, countertransference. Therapists out there will know why that's important. But really creating a comprehensive training program. And we were actually the first ones to offer a year-long training program in the country that wasn't focused on like research, that was really focused on training. And that was even before Oregon existed, and really just believe in this a lot. And when I told some of the other leaders in the space that I was going to start accepting unlicensed people, or like non-clinicians, people were a little bit hesitant to support me, and then slowly realized like actually that is the direction it's going, because we don't really learn most of these techniques. You don't learn in grad school or in med school. So even if you're an MD, like you might be good at handling emergencies, but you also might assume something's an emergency when it's not. So it's, I would say even people with licenses and with degrees should still get extra training in psychedelics so that they really know what they're doing.
Yeah, it's a dramatic, the hospital system and the hospital space, or even the doctor's office space, is a dramatically different way of connecting. In the medicine space, you are not a problem solver. Like, you're not here to fix their problem. Like, the role has totally changed.
Yeah, totally. Yep.
Yeah, and speaking with, again, another service center operator in Oregon, he was actually in support of the more kind of medicalized legislation that's being proposed in New Jersey, because right now there's a large percentage of the population, that believes that you need a doctor to oversee medical things, right? And so,
Mm-hmm.
I think there, perhaps we're in a first stage of kind of changing perception. And right now, having a doctor is what a lot of people would want, So I think there's a disparity kind of between the actual work that needs to be done, or like the skill that's needed versus the perception of who you need to be doing the work, you know.
Yeah, totally. Mm-hmm.
How, I guess we have to kind of consider moving forward, especially as we're getting through in the fall, and maybe this legislation is moving forward, and we'll do more testimony. How do you do that messaging? How do you agree that a doctor, should be around, somehow feels affiliated with a service center in New Jersey, for instance, while also acknowledging that you don't need one.
Yeah, or that there can be certain roles for doctors that aren't, everything. They're not calling all the shots, but maybe they're calling some of the shots around screening, or making sure their medications are going to interact with the psilocybin. I think there can be roles for doctors. I don't agree that you should have like a medical supervisor for every clinic, because I think that could slow down the progress. And I also think there's just an access problem, that I really don't think it's necessary. I think you train people to learn how to screen, and you train them to refer when something's complicated. And most of the times it's not complicated. And if it is, you're going to need a doctor anyways, and you'll just make sure that those people have to refer to a doctor. But I think in the New Jersey model, it will be a referral system. So it's going to be a little bit more than I would recommend as like level of safety that's needed. And I think that's also fine. It just means we have to keep in mind access and making sure that this doesn't create barriers to access for certain people, or create like a resistance because a diagnosis is needed.
Yeah, I think I saw where there was like what's written as is written now. It says diagnosis or symptoms of, which I think is really, really helpful. What's interesting also is in terms of access and driving up costs. I mean, if you have to pay a medical director, you number one have to find a doctor who has he feels comfortable with his license going on something that's federally illegal. There's so many pieces to that, to finding the right person, the right physician, and then having to pay him. And he or she may see it as incredibly risky. And when there's higher risk, there should be, higher sort of exchange in that sense if he feels like he's taking on a bigger risk. So I feel like there's a lot of pieces to that can be pretty inhibitory.
Mm-hmm, totally. And that was something that I pushed for, was the symptom or symptoms of. And I think it's hard to really explain how we're gonna, what does it mean to have symptoms and no diagnosis? It's hard to really explain that, but I think you can have symptoms and then have someone that doesn't really want to get a diagnosis, or has symptoms enough that we think it's safe for them to take the psychedelic, or that it's needed, but we're not labeling them with a diagnosis. I think that's good.
Yeah, diagnoses are really an issue. I mean, when it comes to life insurance, when it comes to work, when it comes to gun ownership, whatever it may be, diagnoses can be something that somebody doesn't want and could potentially keep them from getting treatment.
Mm-hmm. Totally. Yep. And so I think there is going to be, maybe I was advocating for a carve out for police officers potentially. I'm just trying to think of all the people that wouldn't get treated if they had to get diagnosed. And I think it's like police officers, veterans, doctors, nurses, people that are afraid their license is going to be at risk. Pilots. Yeah, totally. So, I mean, we'll see how that goes, but I feel pretty strongly it shouldn't have to have a diagnosis, but it's hard when you're kind of melding. New Jersey is trying to meld these medical and non-medical models. So I think we're all trying to be creative in answering the issues of, the concerns that each person has, and making sure that we're having an eye for safety on every level, and so I'd say, if we're nervous, just do the thing that we think is more safe, and then over time we can adjust the language of the bill. If everything's going well, there's always chances to do that.
Regarding the bill, what it does do is it carves out for the towns to decide time, place, and manner restrictions, which is to say when psychedelic, when a service center can operate, where it can operate, how it can operate. What do you think? Like, what do you think? What kind of range do you think a service center should or should have, or what if you could wave a magic wand? What would those ordinance restrictions look like?
You mean for like zoning?
Not only, yeah, for zoning and for hours of operation and for, yes, anything that could possibly be restricted on a town level. Because we just saw there was an article that came through from the Denver Post this week talking about a town that put in really strict time, place, and manner restrictions. 9 to 5, commercial zone only, opaque walls, probably zoned for medical, maybe in a medical office only. And we spoke with some people out in Colorado recently who said they're seeing that as kind of there's a next wave now of work to be done, which is talking to towns about this. It's becoming a reality out there because they're behind Oregon and ahead of New Jersey. They're right in this middle ground. They're in this transition period where the towns are now taking action. And so, what kind of restrictions would you, I guess, maybe not want to see,
Yeah, I mean, for me, I think about like what is the easiest way for people to operate, and I think just really helping towns and groups understand that it's like when someone's in a journey, they're typically just like laying there and listening to music, and so I think there's this concept that it's going to be like chaos, and it's really a very calm thing. Once in a while, someone might like get upset, but it's not it like to me, I as a person in a city, like I would be totally happy to have a neighbor running a service center. Like I would have no concern that it would be disruptive. I feel like someone having a baby is more disruptive than someone running a service center. And I have kids, so I'm not like anti children, but it's like a dog barking or a baby crying. It's it wouldn't be any more disruptive than that. But I would say it's really important for me to see overnight stays being allowed because a lot of times people need the safety of like processing afterwards in the same place where they did the treatment. So I think it really restricts things if you have to like get people in for their, like in Oregon, you have to get in and out by midnight unless you can document there was some reason they couldn't leave. And so really overnight stays are not allowed. And partly that's also because the zoning is required to be commercial, and overnight stays, there's complications. Like if you overnight stay in a clinic, it needs to be zoned more as a hospital in some places. So my goal would be to say, let's think about like how would you make retreat centers and make that the restrictions that would be the baseline. So like people can stay overnight, you can have outdoor space. I would love if it could be in a residential, like you get a really beautiful residential home in somewhere out in nature and run it there. I don't think that will probably be allowed, but having as much flexibility in the zoning as possible. Because in Oregon, most of the service centers are like downtown storefronts, and that's just not where most people want to be doing psychedelics. You want to be like in nature, have surrounding areas. Like if you're having a difficult time processing or crying, you might want to walk around and cry and look at the birds, things like that. So if it's zoned in ways that you can't really have those spaces, then it makes it harder to give people really good experiences. Overnight stays, no restrictions about time leaving, and as flexible of zoning as we can. I think it's super important, and we advocated for that with Colorado too. And one of the biggest things that I pushed for was that I think the places should have flexibility in what they're designated as. So it's like in Oregon, something's just a service center, but if you can have like a medical clinic that also is a service center, or a medical clinic that also can turn into treating people with these medications like psilocybin, or have it be maybe it's someone's home that is a really beautiful home in the middle of nature, and then they have retreats there, and call that a service center for that week. So they're working on that, and I think that feels like very much more doable, and it also feels like it's going to lower the barrier of access to different groups. So you really want to see as many people, as many businesses as possible popping up and kind of helping us solve problems about how this can be accessible to the most people as possible.
That's a really great idea. This idea of flexing, I never would have thought of the idea of it. The idea that something was a service center meant that it maybe couldn't also be a wellness center. It couldn't also be something else. I would have never thought of that. But that
goes back to what we said earlier about just more kind of holistic look at it, wellness generally. And perhaps, that's where we can do a slight pivot in messaging away from, the John Hopkins like photo of someone with a eye mask and headphones, that why couldn't you do that from 9 to 5 like a doctor's office? I think that's what one of the council members in the Denver Post had said. They said, if this is just like that, then 9 to 5 should be fine. You go to your dentist 9 to 5. This is like a dentist, effectively, and I think it comes from a misconception of what the paradigm is. It's a completely different paradigm. But then if you start arguing for a different paradigm, it starts to undercut your one and done pill argument. So I think it has to be a little slightly pivoted, nuanced, change to that one and done. It's like, yes, it can be one and done, but one and done has to happen in a more flexible environment.
Totally. Yep.
Yeah.
There's also a huge difference at least in my experience, between like morning daytime versus evening. There's like a different, I'm going to say something that's not very professional, but there's a different energy between the daytime and night. Daytime can be very much more activating, where nighttime can feel very much more introspective, and like that can be different for different people, but giving them the flexibility to do what they feel called to, I think is also, to me at least, is like a really big piece of this. Is different companies can create different offerings, and these different offerings will speak to different people. And the more flexible we are with that, then we can just meet people for what it is that they want out of this experience to get the most healing that they can. There's not like a one scenario that is right for everyone. And maybe the doctor's office is right for some people.
Right, totally. And I think some people love white-coated humans. Some people get very nervous around them. But I would say it's also just like keeping in mind some of the more traditional practices, like ceremonial practices. Some Indigenous people prefer working at night, doing night journeys. So keeping it open as much as we can to different types of practices so that we can be inclusive of different practitioners. That also feels very important to me.
That's an interesting point. That hasn't come into the dialogue from what I've seen in New Jersey, the talk about different traditions. Maybe that's purposefully so. I don't know, again, maybe to sterilize it a bit. Perhaps.
Yeah, that's because you guys sorry, Joe.
No, and perhaps that would be an interesting way to bring in the idea of lowering the bar to access.
Yeah, and that's something that you guys actually include at Sound Mind in your training. How do you guys kind of pull in the ceremonial aspect into the training?
Yeah, so we it's an interesting endeavor. So we have several different teachers, including Belinda Racho, Paula, who is Colombian from the Santa Marta region and lives in Costa Rica, Amber, who is Costa Rican and has studied under lots of different lineages, Claudia Cuentas, who's from Peru, and we bring them on and we do a lot of experiential components around plants. So we have a plant dieta as part of the one-year program in which you're dieting a non-psychedelic plant just to make a relationship with the plant. When we do international psilocybin retreats with Cadence Retreats, it's another company, but it's us. We have people experience ceremonial. So they aren't learning to become a shaman, but they're learning how to experience that modality, to respect it. And throughout the training program, we have people come on and just give a sense of the worldview of different Indigenous traditions, so that it's not just like a medical model. And then we ask people to really look into themselves and take, this medical model that's more sterile, eye shades, playlist, and figure out what feels comfortable to incorporate based on what they've been taught and what feels culturally appropriate, and really be open to different ways of practicing. So yeah, people love that aspect of the course.
Yeah, that's a huge. I know I've mentioned this multiple times that I keep eyeing your program, and that's a huge draw for me, because many programs do seem very clinical in their presentation, and so it's kind of beautiful that you have the MD background, you have the clinical background, but you also have this other experience to sort of pull together. I think it makes you guys really like a really special program.
I think
You
so
know, I
too.
know
Thank you.
I know, like, Colorado is opening up their application process for facilitator programs. And I know you've kind of had you are involved in, to some level in all states. What would you say is the big difference between Colorado and what is facilitator training in Colorado versus facilitator training in Oregon?
Great question. So we actually just applied today, which is exciting. We just sent in our application like 2 hours ago. So each Colorado and Oregon, our curriculum we basically created outside of states. So these are the things that I thought were important for people to learn, and we cross-referenced it with different curriculum advisors, and really came up with a curriculum before any state was legalizing. But as they're legalizing, the biggest difference is that there's certain number of hours that you have to learn about Colorado law, and then in Oregon you have to learn a certain number of hours about their specific like paperwork and law. And so the way we're doing it at Sound Mind is we're keeping the Oregon as baseline, because we've already incorporated certain weeks that you learn all the paperwork that Oregon has, and then if people want Colorado as well, they'll have, I think it's like an extra, there's 25 hours that have to be somewhat Colorado related, but we already have a lot of those hours that are that content. And so I think it'll be like 5 extra hours that people will just sit in on a Saturday if they want Colorado as well. And then there will be different levels of practicum required and different amounts of supervision required after the program is done. And I actually think it will be really interesting. I think that supervision is very, very important. I think it is going to be a little bit, I think the different programs are going to have to do some work on figuring out how to create that supervision in a way that's accessible to many people. So our classes are like 60 to 80 people. So it's like over 6 months after they're done training, what type of supervision can be done that can be done with more than a couple people. And so what we're thinking of doing is doing a weekly supervision for people that are doing integration and other like space holding activities, and then giving them feedback. Yeah.
That's really interesting. I didn't realize that that they had added that requirement in there as well. And yeah, that's a tricky one to sort of figure out what is that. Would that include things like even cacao, like other sort of modalities of holding space, but then also doing the integration that comes in after hape or whatever else may be legal?
Yeah, totally. Yeah.
That is really, really cool.
Yeah, and I think that New Jersey should do something like that too. And I don't necessarily know that it has to be written into the bill, but it's like just thinking of all the different types of trainings that we know of, like social work and nursing and doctors, and it's like everyone has some amount of ongoing supervision after they graduated their core program. So I think that is the direction we'll go. It's like every educational process has that. So I do think it's more about figuring out how that will look, and or is it going to be different organizations that pick that up, or is it the same ones, and how that will look over time.
Speaking of New Jersey, and that's, we're not going to get the specifics on the requirements for the New Jersey facilitator training programs. I think they have 24 months to get that up and running after the bill is passed. What are some things that you hope to see included, after the work you've done with Colorado, with Oregon? What do you hope to see in New Jersey beyond what you just shared?
Yeah, I mean, I think New Jersey has a possibility of being like very integrated and like into the medical model and like really pulling into people with licenses. And I think that's what Colorado's trying to do as well, because I think that is one thing that's been a little bit hard with Oregon, is that you have to, even if you're a therapist and then you're a facilitator with psychedelics, you have to have them in different places, and you have to like take off your therapist hat and then put on your facilitator hat, and you can't be using the skills together. And I think that's felt limiting to certain people, or felt like a little scary to be licensed and then working under those parameters. And I think Colorado's trying harder to get those integrated. And I think New Jersey, it feels like, because it's kind of coming from a non-ballot initiative direction, and there are many doctors involved in the like political decision making, that it will be more integrated. And I think there's ways in which that increases and decreases access, but I think it will potentially create more people that can be involved right off the bat. I think, when I was testifying, they did ask me a lot about like physical side effects or physical dangers. And I think there's there's a little bit of too much caution around that, because that's really not what we worry about in psychedelics. If someone can run up a flight of stairs and not have a heart attack, they can probably take psilocybin and not have a heart attack, But it is like, because these substances have so much stigma attached to them, it's like everyone's overly cautious. And even with ketamine, because it's off-label use with psychedelic assisted therapy, we measure blood pressure and heart rate before the session, and we don't do continuous monitoring during the session, because I'm like, what am I going to do? Like, treat their blood pressure in the middle of a session? And there's never been, as far as I know, the last time I checked, there's never been like a ketamine-induced stroke from spikes in blood pressure. But everyone's so cautious because they don't want it to. The ketamine's been used for decades. We know a lot about it, and it's really, really safe. And we're giving like 1/10 the amount that you give in anesthesia. So in order to even have like anything respiratory go on, you have to give 10 times the amount we give. But we're still extremely cautious, because we all feel like we're doing something weird, or that like someone might look into it and think it looks strange. So it's like the same thing I think is happening with psilocybin, that it's extraordinarily safe, and there's so few incidences of issues. And I would say if you screen people really well, the incidences would be even lower than they are now, which is like minuscule compared to any other drug. But so screening for heart issues, screening for psychological issues. There's a lot of different things that we can do to make sure that we're being safe. But I would say that getting a little bit too hung up on the physical side effects is something that I would just like not worry too much about. I did say in the hearing or in the meeting, I said we could get everyone trained in CPR, and that made some of the folks nervous, because they were like, oh, we're getting CPR trained, that means it's dangerous. And I think that everyone that gets on a plane should have CPR training, like just like as a human, just no CPR, But I, in my mind, as a person, a problem solver, I'm like, you guys are nervous, I'm not nervous, but if you want to do CPR, well, let's just get everyone CPR trained, require that, we require that in our clinic. It's like, you don't know if someone's, not even because you gave them a psychedelic, but they could just need CPR. Who knows? People pass out. But yeah, I think there's a little bit too much obsession about the safety aspects that I think are less concerning to me than just like really focusing on like screening around past mental health issues and just making sure someone's in the right place, making sure they really desire to change or they have a reason, that they have enough support. There's a lot of ways that we screen to make sure someone's appropriate. And I would just say, focus on that. And yeah, I just really want to be able to buy a nice retreat center. It's all about zoning for me.
On the issue of ketamine, I mean, is it worth drawing an analogy between ketamine and psilocybin for the purpose of talking about, we're already doing this in Philadelphia and Pennsylvania and New Jersey, like these ketamine centers already exist. That's part one of the question. Is it worth comparing them and then saying, look, we're already doing it safe. We haven't had much by way of any emergencies. And then how do you then differentiate that? I guess the second part of the question is, let's say you have someone come in and you can offer them either ketamine or psilocybin. How would you distinguish between the different offerings?
Yeah, that's a great question. So I would say I wouldn't compare them. Like, they have very separate mechanism of action, so that they're not really similar categorically. But I would say what they both do is they do uncover unconscious material in different ways. So in that way, and the skills of sitting is very similar. Psilocybin, if someone's a little bit more active, can move, can talk a little bit more. Ketamine is more inward, and people are laying more still usually. Ketamine, people are going to have like heightened auditory senses. And so you need to be really careful about not making loud noises, that kind of thing. So there are some slight differences. I would say, in a lot of ways, it's like, I think they're pretty much similar safety profiles. I would say psilocybin might be even more safe, because you can get, well, I don't know, maybe about the same, but just a little slightly different. I think, when I started out, I really wasn't interested in ketamine at all. I was like, okay, I'm going to start a clinic for MDMA. And then I was like, why is this taking so long? Fine, I'll do ketamine because that's what everyone else is doing when they like set up a clinic and don't have anything else to work with. And I have been extremely surprised with how much it has helped people. And it's like, I keep thinking about how grateful I am that I am seeing people get better in ways that like I've never seen before. Like, to be in that position of seeing that, witnessing that, holding that space is like, most people will never see that in their lifetime as a healer.
That's great to hear. Yeah, I represent.
I would say in a lot of ways,
Yeah.
I think ketamine can be really good for people that are like very depressed and suicidal. It can be good for different things, but in general, I think if it's almost like psychoanalysis versus CBT, like cognitive behavioral therapy. I think psychoanalysts or psychodynamic people really criticize CBT because they're like, oh, it's just like a program. You give homework. It's not like real depth therapy. But some people really need that. Some people that are like really not okay, in bed, suicidal, CBT can really help get the person out of bed, and then when you're like, okay, you're functional, you got a job, and now let's dive in and see what's underneath it all. But like, you don't necessarily want to start with uncovering someone's unconscious when they're like in bed wanting to kill themselves. And so it's sort of like, when someone's more severe, I would, CBT can be more appropriate for them. Or if you're going to do something more psychodynamic or like depth, you might do less frequent. You're not going to do everyday psychoanalysis with someone that's like not very stable. And I think the same thing with ketamine. It's like, if someone's really not doing okay, sometimes psilocybin can make them more confused. So it's almost like you can use ketamine to stabilize the person, to get them functional, to get them like not in like as high alert. And if you, we've gotten really good at Sound Mind at just like figuring out dosing. And some people that I've actually recently been treating someone who had a really difficult psilocybin journey, who has a ton of trauma. And sometimes the trauma with the tryptamine class of drugs, which is like ayahuasca, bufo, which is 5-MeO, psilocybin. You can sometimes trauma can come up in weird ways that don't really make sense in those medicines. And so you really have to screen to make sure someone's like ready to have like visions and like, ready to process things that might seem a little bit weird. Ketamine is a lot more straightforward. So you treat someone and they usually don't have anything too confusing. It's really hard to re-traumatize someone with ketamine. And it's also, you can give it with antidepressants. And so we're still kind of figuring out with psilocybin how safe it is to use psilocybin with someone on antidepressants. It's probably safe, but there is this slight risk of serotonin syndrome, which again, I don't think has ever happened. It may be a more theoretical risk, but you can cause too much serotonin to be happening if you have an antidepressant releasing serotonin and you have the psilocybin, and it can cause like increased body temperature and sort of muscle issues and things, and it can be actually life-threatening. Again, last time I checked, it's never actually happened, but it may have happened it's never happened in like a clinical trial. It may have happened in like underground settings in which people might be mixing more medicines that they haven't really told you about. But ketamine can also help people like taper off antidepressants so they're more ready for the psilocybin. I think psilocybin can give people more of a sense of purpose. Like people will come out of journeys with psilocybin and have a sense of like, this is my purpose in life, or this is really what I want to do, or I had this vision, I want to reach that vision. I would say ketamine, that can happen, but it's not quite as often. It's more like you're getting someone to be like functional, not feel like stressed all the time, and like get their life together. And then I envision a world in which then I can go from ketamine to psilocybin and say, okay, now we're ready for psilocybin, and get it all set up. It's like you can do singing, you can do ceremonial, you could also do playlists and eye shades, but we're really going to like create this preparation phase, and then we're going to go through your journey phase, and then we're going to help you process. And I really think you can kind of create these like sequences for people that could be really effective.
I love that idea of the ketamine. And for those who are not familiar, like ketamine is a dissociative, and I love the way that it just sort of like pulls you back away from those pieces, those thoughts, those ruminating thoughts, those fears can pull you back away from it. I know there's been some discussion around the danger of people coming off of, just on their own, coming off of SSRIs or SNRIs, these antidepressants, and then sitting with a psychedelic like mushrooms. And then on the other side of that, having like a rebound with their depression. I feel like kind of giving a little bit more supportive aspect of, or let me actually ask you that question. Do you think giving a more supportive tapering of that antidepressant would make that more successful?
Yeah, I mean, I think this is getting researched now. So I think in like a year from now, we'll know a lot more about exactly how things should work. But I think I think there's a couple things going on. I think there in the past there's like a lot of lack of research about what medications interact with psilocybin, and so out of this fear, facilitators have told people just stop taking everything. Like, just, I don't want you to be on anything, it'll make me feel better. And actually telling someone to stop taking, I had someone I did ayahuasca with in Costa Rica, and they told her to stop taking her thyroid meds. It's like, oh my God, like all of us have thyroids that are giving off the hormones, and it's like, that's just endogenous. And now she doesn't have a thyroid, so she should take it. We're all getting it, just not people without thyroids. But stopping taking it is like taking away like a vital aspect of being human. So she had a terrible journey, like a terrible week. Like, I feel so exhausted, this medicine's not working. It's like, it was really, she was like off her thyroid meds. It totally made me crazy. And I didn't know about that until after, but there have, I think in plant medicine world, there can be like this sense of don't be a pure vessel, but it's like a lack of understanding of which things are, thyroid meds are, you're still a pure vessel if you're taking your thyroid meds. And we've also done this, we did a project around trans-affirming care and psychedelics, and just talking about like, don't tell someone to stop taking their hormones if they're transitioning or they have transitioned, because then it's like, it causes all these kinds of stresses that they shouldn't have had. So there's that. And then for antidepressants, there's the two concerns that people have are you going to be on two things that are going to interact and then create something like serotonin syndrome, or are you not going to have the effect of the medication or the treatment because you have the wrong, like your neurotransmitter receptors have been downregulated because you've been taking like Zoloft for 10 years, And I think that the second is much more of the real concern, is that you don't get the benefit. And I've actually seen, or you don't get the full journey. So you're not like going in and having an experience. It's like sort of a muted effect. So you've got all this like excitement. You're going into your journey. It's like, it never gets you there, and that can be really disappointing to people. But tapering someone off isn't really going to change those neurotransmitter receptors. It takes years, so if someone's been on Zoloft for 10 years, it's going to take years for them to regrow those things. And so oftentimes those people just need higher doses, and higher doses can scare certain people. And there also is like, maybe there's a higher risk of side effects because you're giving a higher dose because of the neurotransmitter issue, but you're also giving a higher dose in the system. So are they going to have like side effects that are scary? But I have seen some of the retreat centers in Jamaica say, like, one of the benefits of coming to us rather than going to Oregon is we can serve you more than 5 grams of mushroom. We can go up to like 10. And I was like, oh, this sounds like a lot. But also, it is true that people that have been on antidepressants, it's like they might really need this treatment, and they might need more than 5 grams to have the effect that someone else would have at 5 grams. And so, and I think that the worst case scenario is if someone abruptly stops. So if like someone just says, stop taking your Zoloft, stop taking your Celexa, this stops, and then they have this like crash that they're like, maybe going into some withdrawal or suicidality, and then they're taking a psychedelic in the middle of that withdrawal period. That I think does sometimes happen in like international retreats. They just say like, stop taking it, or people might sometimes stop taking it on their own because they don't want to disqualify for a retreat. And I think we just tell people like, don't do that. I'd rather you be on a low dose and us work on it together, and like really weigh the risks and benefits rather than going into some sort of like taking away something that you've been needing for years, and we don't know if this is going to help you, or even if it does help, it might be many days between that you're kind of in no man's land,
Totally. And I think that's an interesting, sorry, Joe, go ahead.
No, go ahead.
I was just going to say, that's an interesting piece where, especially if it's happening within the United States, like for somebody to tell you, whether it's the underground or where this is happening, to tell somebody to stop taking their medication, because like if you're not a prescriber, that is not actually something you can do. And so, these things, I think people have to be really, really, really careful about, particularly in the underground.
Yeah. I wanted to pivot slightly from treatment to like wellness or like personal growth. Can you distinguish, or is there a room in treatments for personal growth? Like, would there ever be an instance where you have somebody say, I really want to do like a psychedelic treatment. It's really for personal growth, not for like I'm a well person. Is it acceptable to say, yeah, no, I think you can get something out of this?
I think that's a great question. I don't know if I've ever met a well person.
I love you have that in the law. Like, there's not a well person.
Self-asserted well people, self-identify as well.
Yeah, well, I will say in our ketamine retreats and even in our psilocybin retreats, I require people to have, like, for myself as a prescriber, like a prescribing doctor, I require people to have a diagnosis in order to give them medicine at my clinic, which is a treatment facility. It's not like a training facility, it's a treatment facility. And only once have I been screening. I would say, okay, one time it was a non-trainee and one time it was a trainee. And the trainee, there was one person that filled out all their paperwork, and then they said it was like they had no ACE score, they had no trauma, no divorce, no nothing, feel good, no anxiety, no depression. And I was like, well, I can't, you can come sit. I'm not going to serve you medicine, like, because I need a diagnosis. And I said, so that's your choice. Like, either go home and try again, or. And actually, it turned out that person did have trauma. They just weren't telling me. So there was stuff going on. They just were, didn't want to write it down. So I was like, okay, we'll give, I think we ended up saying there was some anxiety. And then I had another person in the very early days of Sound Mind. And we were the first psychedelic assisted therapy clinic, as far as I know, on the Eastern Seaboard, which is like, there were ketamine clinics, like infusion centers, but no one doing the therapy part. So when we were starting, it was like we were really the only ones. And I had some mentors on the West Coast that I could call when I was like, this dosing, I'm not sure about. But I had one guy that came in and he said, I'd like to feel better. I run marathons and I feel pretty good, but I think I read about this in one of there's a lot of press when we first started the clinic. He's like, I read about it, I wanted to try it. And so I said, okay, like, maybe he's slightly depressed. We took a scale. And originally I didn't want to treat anyone who was like severe, because I was afraid that if someone's suicidal, like what happens if they go, what if they're so unstable that I worsen it and something happens? But he didn't actually get that much benefit because he actually was pretty okay. He was just like, I don't feel like I need to take a day out of my week and pay this money because I'm actually realized I'm pretty fine. I'm pretty happy. And I was like, okay, well, great. Well, don't need to come back. So that was fascinating. And since then, we've been taking people who are more severe because it just noted, like, I just think you get more bang for your buck of time and office space. And just like, if you're treating someone who's really not functional and not okay, and you can see someone who's been chronically suicidal or depressed their whole life get better. It's like, there's nothing better than that, really. So now we take people that are a lot more severe. I think there's definitely like a role for, like, in recreational settings or even solo journeys. It's like, yes, there's always things that people can learn. I think life is life is suffering, said the Buddha, samsara. And so I don't think there's anyone on the planet that doesn't have some healing to do. So I think it's like how you define what is, like, like, no diagnosis, just like wellness, getting well, people getting more well. It's like everyone has difficulties, even if it was a bully in 5th grade or like I don't know, you had to sell your house because you couldn't afford the mortgage payments. There's always something that needs to be processed.
And I guess I asked because part of the recital section of the legislation in New Jersey is, the last part is, to foster wellness and personal growth. So there's like a stated recognition that there's a room for that. Again, it's kind of contrasted against the need for hopefully not a full diagnosis, but some kind of indication or something that would give rise to a referral. But yeah, it's good to, it's just good to talk about that for a second, just to express,
Yep.
yes, like everyone can grow, perhaps, and maybe there is a place for that. And hopefully in New Jersey, as it builds itself out, that can be a legitimate reason. It's like, I want personal growth, and I think I can get it out of going to do a group
Totally.
sitting, beautiful place in a nice residential area.
And I'd also just say, like, there's a lot of different types of childhood traumas that aren't reflected in diagnoses. So like the adverse childhood experiences scale, which, like, it's not perfect. There's areas in which it could be improved, like for cultural and like diverse populations, but in general, I feel like it's a pretty useful scale to use with people. So it asks them, like, did your parents get divorced? Like, before age 17, did you have a divorce in the family? Has anyone been incarcerated? Was anyone, like, addicted to a substance? Did someone ever hit you or yell at you, or sexual abuse? It has all these things. And so that, for me, I take that scale on everyone, because I was always, if there is something in there, it comes up in journeys. It's like, because it really makes an imprint when you have young, like, childhood trauma. And that's not, usually those don't qualify you for PTSD. You don't get PTSD because your parents got divorced, but it's usually there's observing people fighting and stress and moving houses, and there's a lot that can go into that. So I would say that's the other reason I would fight for no diagnosis needed, because there's just a lot of things that are difficult that don't have diagnoses, and those people still deserve to be treated. And if people feel well, then they should feel even more well, for sure. I think that's important. And I have an uncle who's like an investor, and he's done pretty well, but he said, like, I don't know about this idea about psychedelics. What if someone wants to just come into your office and do drugs? And I was like, if someone wants to pay this amount of money and come into my office and talk about their early childhood life and trauma for 6 hours, they're like, great. Like, there's a lot easier ways that you can do drugs. You can just buy them on the street, and you can go out to a party. So I think, like, I don't feel like I'm giving people access and aren't actually trying to heal or get better, or even just trying to make their life make more sense, like find a sense of purpose. I think that's a real good reason to do psychedelic journeys.
Yeah, that's definitely an extreme example. Yeah, and I think that would be, you'd be hard pressed to find somebody who's that dedicated.
Right?
Yeah, it can be a pretty tough experience.
Yeah, it's tough. It's hard work, man. It's hard
That would
work.
probably be their trauma, that they're coming to you paying a lot of money to do drugs, and then turns out they're actually getting well.
Yeah, right.
The joke's on them.
Yeah. But I would say it does increase access for certain people who think they don't need therapy. And I would just put my dad in that category. He's given me permission to talk about him, by the way. But he didn't think he needed therapy. And then it turned out that he just had like stuff that was really deep that he realized he probably would never get to in therapy, which is also valid, because it is hard to get to the affect of trauma. But I think there's a lot of people that like that would be embarrassed to go to a therapist's office, but saying they're going to like a psychedelic clinic is cool, you know, for some people. And I do think in some weird way that does increase access too for people that are like, I don't have a problem, but I'm just doing something that, you know, I saw on Netflix. And so it's sort of like, I don't have to tell my neighbors that I'm going to get trauma treatment, you know.
There's a big distinction there between going to a talk therapist and having some kind of active experience. And unlike talk therapy generally, right, psychedelics can be done in a group setting and it's communal. There doesn't seem to be a lot of unless I'm wrong, a communal aspect to talk therapy generally. You know?
I mean, there's group therapy, but yeah, it's usually less emphasized.
Yeah. And hopefully, you know, I think New Jersey, as of right now, would allow for that. There's nothing in the bill that says you can't have groups, and hopefully, as the rules come out, that'll stay in place. That'll be stressed. Yeah.
Yeah, totally agree. Yep.
Well, thank you so much, Sarah. Did you have anything else? Or
no, not at all. Dr. Hannah, do you have anything else you want to add? This has been really amazing. I feel like we could go on for another. Like,
I know we could just like monologue ourselves into the sunset.
Yeah, this is really awesome.
When NBC like started interviewing me for different things, they're like, "Oh, we want to film a veteran. Do you have a veteran?" And I was like, "I'm a veteran." And I was like, "Okay, let's film that." And they're like, "Oh, do you have like? There's all these companies going bankrupt. Do you have an opinion about that?" And I was like, "Yeah, come on in." And they're like, "Oh, there's this thing about microdosing. Do you have an opinion about that?" And I'm like, "When are you gonna learn? I have an opinion about everything." Like, come on down. I'll give you it might not be the opinion you wanted, but I'll give you something.
I like it.
Yeah.
I like it. It's been super awesome. And, you know, hopefully we can do this again sometime, especially as things start to sort of shift and meld and we learn a little bit more about what is going to be happening in New Jersey, and wishing you tons of luck on your adventure in Colorado with Sound Mind.
Thank you. Yeah, I'm excited. Now we're going like 3 states, you know, it's like, woof, it's exciting. So thanks for all of your work in New Jersey as well. And I'll see you both soon, I'm sure.
Yeah, we'll see you soon.
All right. Well, take care.
Bye.